you very much, John, and to the committee for inviting me. I had hoped to be able to present the new guidelines in hypertension to you, but they are not yet published. They will be published in November when the American Heart has their big meeting in Anaheim, California. So if any of you are going to go there, this is something you want to look for, and I'm sure that what we say will be of interest broadly. What I'll do then is talk a little bit about how the emerging data might affect the existing guidelines. And of course, the elephant in the room, as we say in the United States, is the SPRINT trial. This is the one that's going to make the big impact. I can't tell you what is going to be in the new guidelines, but I am on the committee that's writing them, and so I will give you some clues or try to stimulate your thinking as we go along the way. One thing which has been ratified for the last two major guidelines has been the importance of a healthy lifestyle on the treatment of hypertension. And so such things as reduction in weight, eating the right diet, which in the United States is a Mediterranean-style DASH diet, restricting sodium to around 2.4 grams, 2,400 milligrams per day. In the NIH guideline we published, we saw that 1 gram reduction in sodium for anyone with hypertension could have a major impact. Physical activity and keeping alcohol intake in moderation. So every time we see a patient with hypertension, we should be sure to look at these behavioral changes which can make a big difference in blood pressure. Now, we'll talk a little bit about the guidelines that were published as from the committee known as the JNCA committee. For those of you that think guidelines are too long, I would encourage you to read this. It's only 13 pages and only has 9 recommendations. It's highly based on evidence. So not make a recommendation in here if you didn't have strong evidence. When we write guidelines and we talk about evidence, the real challenge is to move from observational data to what we've learned from randomized clinical trials. And it's a normal human characteristic that we rely on observation. When we are children, if we touch a stove and it's hot, we remember that. These things are hot, they hurt. When we look at populations of patients and observe them, we know that as blood pressure goes up, we see here the risk of cardiovascular disease goes up. So increasing blood pressure is associated with higher cardiovascular events. The question is, how high should we let blood pressure get before we start treating, and how low should we treat it? The fact that the events increase, the blood pressure increasing, doesn't necessarily tell us where or when to intervene. Now, there are some other observations or findings. For instance, if we look at incremental changes in age, for any decade of life, a given blood pressure assumes a higher risk. So a systolic pressure of 160 is associated with a much higher likelihood of cardiovascular events at age 80 than it is at age 50. This enters into some of the discussion. And then finally, we do know from a large number of trials that treatment of patients with combined systolic and diastolic hypertension is effective in reducing fatal and non-fatal events and all-cause cardiovascular mortality, and also the treatment of systolic hypertension has similar benefits in terms of cardiovascular events, reduction of them, and all-cause and cardiovascular mortality. The real question then is when should we start treating and how low should we go? Now, at the same time that our group at NIH was working on the hypertension guidelines, the Europeans were working on modifying their guidelines. And I'll just call your attention to their findings using evidence in the algorithm. What they saw was that treatment of systolic hypertension, and these are the starting points in elderly patients, is associated with a reduction in cardiovascular events. If it goes from yellow to green, there's an improvement. And you can say, in general, if you're talking about treating patients with systolic pressures around 160 and treating them down to close to 150 seem to have a benefit. There is only one trial that actually treated below 140, and that showed, interestingly, no benefit. So the Europeans were coming up with data that suggested in older patients that treatment of systolic hypertension resulted in improvement, but they really did not have evidence, strong evidence base below pressures of around 150 that there would be a benefit. They also, at that time, had discussions about what drug should you use. And of the three major guidelines that were available, JNC7 suggested use diuretics. And that's based on ALHAT. The Europeans said, we don't care what you use as long as it lowers blood pressure. That's the important thing. The British said, as far as we're concerned, we don't like diuretics, and we don't like beta blockers. Use calcium channel antagonists and ACE inhibitors. So a lot of difference in opinion as to how to treat blood pressure. Now, as we began to look at the NIH at the data, we looked at trials in older patients, and there were three that treated patients with blood pressures less than 150, and all of them showed significant benefit. However, when we looked at the two available trials that met criteria, those two that had treated for less than 140, 136 and 137, failed to show any benefit. And so our findings were similar to the European findings, and that is it was hard to find data that treating to less than 140 had a benefit. The Institute of Medicine told us if you can't find a randomized clinical trial, you shouldn't recommend it. What the committee said was that in the general population over the age of 60, start treating when blood pressure gets over 150 and treat patients to less than 150. That there was strong evidence from randomized trials that there would be benefit. Given the fact that in the United States, many patients that were older were being treated to less than 140, the committee also made this recommendation, which has not received as much press, and that is if you're treating a patient that's older to less than 140 and they're not associated with any adverse effect, don't worry about changing it. If they tolerate the medication, it's okay to go to less than 140. Now, the committee also looked at diabetes, and the ACCORD trial was out, which is looking at close control of hemoglobin A1C and also treatment of hypertension. And the ACCORD trial failed to show any benefit on the primary outcome of combined cardiovascular events. It was non-significant, treating to down under 120. They did, however, show a reduction in stroke when patients were treated to blood pressures less than 120, and this is a pre-specified secondary endpoint. The committee also found the differences in response to medications. Here from all that, one can see that there is a difference among African Americans in terms of response to clothalidone versus the ACE-ARB combination. ACE inhibitors actually were associated with higher stroke, and so this favored clothalidone. Also, the LIFE trial showed increasing stroke with beta blockers, and in this case, atenolol. The problem, of course, is that beta blockers may not have a class effect. The toprolol, carvedilol, they have different effects than atenolol, and Nuderol. One has to be careful about data from the beta blockers. Nevertheless, there was an increase in stroke associated with beta blockers, and also an increase in new onset diabetes. For this reason, the committee agreed with those from UK that beta blockers might not be used as the first recommendation drug. They came out saying use 3 medications as your first choice: diuretic, calcium blockers, or ACE or ARB, and reserve the use of beta blockers for those with compelling indications, following myocardial infarction, heart failure, arrhythmias. These would be the type of situations where a patient with hypertension would be treated with a beta blocker, maybe as the first choice, a compelling indication. The recommendations were actually quite easy. Across the board, the committee recommended that everybody should be treated to less than 140, with the exception of over the age of 60, where they should be at least under 150, and if they tolerated blood pressure, 140 would be fine. So we got away from the previous JNC 7, which said if you have renal disease, if you have diabetes, treat to less than 130, maybe heart disease. Hard to remember which of these things. Strictly from the evidence, everybody should be treated to less than 140, with the exception of those over the age of 60, where the evidence is strongest at less than 150. And then the whole issue of the use of inhibitors was discouraged in the African American population, with the exception of those who had diabetes and chronic kidney disease, where chronic kidney disease was an indication for the use of ACE or ARBs. Now, the thing that has complicated matters has been the publication of SPRINT, which is asking a very important question, and that is, what about treating to less than a 120 compared to less than 140? These are very important data. I call your attention to the fact that the inclusion in SPRINT were patients over the age of 50, so it's not everybody. The patients with blood pressure between 130 and 180, and the patients also had to have high risk, either known cardiovascular disease, chronic kidney disease, or an increase in Framingham risk of greater than 15%, also over the age of 75. So there have to be three things present in order to get into SPRINT. You have to be over the age of 50, have to have a blood pressure between 130 and 180, and one of these high-risk criteria. In addition, if you had diabetes, you're not in SPRINT, and if you had stroke, recently you were not there, and patients with HFrEF, heart failure with reduced ejection fraction, were not included. So it's very important to understand that not everybody is included in this question. Does 120 as a target give you better results than 140? It's a great study, close to 10,000 patients. For the United States, it's very helpful because all the patients were from either the United States or Puerto Rico. We had 30% that were black, 36% women, and more than a quarter over the age of 75. These are the type of people where we need data. The trial was stopped early because of the reduction in overall cardiovascular events and all-cause mortality. There are pre-specified groups, the older versus the younger, men versus women, ethnicity, chronic kidney disease, and cardiovascular disease that are very important. These are the results in SPRINT. Populations treated to roughly 136, that is less than 140, were compared to those treated to a target of less than 120. They only made it to 121. So if you're writing guidelines based on randomized trial right now, you have a problem. You say treat to a target, but the group didn't make the target. We made 121. So do you make the target in your new guidelines to treat to 121 or less? Or do you say treat to 120 and hope that you get to at least 121? Or maybe you think that the treatment strategy ought to be higher. So keep your eyes on what the target may be when new guidelines come out. Call your attention to the fact that if you look at the patients treated to less than 140, shown in yellow, in general they were treated to pressures around 135 or less. And if you look at the patients that were treated intensively towards a target of 120, that you're getting down, the majority of them are treated down at least under 130. Now the results were striking. The primary outcome occurred early. The trial was discontinued, stopped after 3.25 years because of a significant reduction in the primary endpoint, 25% reduction. If you break this down and say, well, how is this happening? The major factors were a reduction in heart failure, and a reduction in cardiovascular death. Interestingly, there was no reduction, no significant reduction seen in stroke, which surprised me. I would have thought stroke and heart failure would begin to show up. We do know that treatment of hypertension has a very major impact on heart failure, and that certainly powered these changes. There were serious side effects. You can see hypertension occurring, syncope, electrolyte abnormalities. So treatment towards a target of 120 comes with a price, and the price of these side effects. If we look at the groups, though, we can see that the benefits held. Whether they had chronic kidney disease or not, whether they are under 75, over 75, men versus women, African American versus non-African American, and you can see that a variety of systolic pressures, less than 132, and so forth, we saw significant benefits that were not seen at over 145 for target rates. These are the findings that we had in the older patients, and they're very striking, with number needed to treat for 28 in the overall primary outcome if you're over the age of 75, and NNT of 41. This is a 32% reduction in all-cause mortality. So the treatment of older patients who meet the criteria in SPRINT seems to be better when they are treated more aggressively, even down towards the target of 120. We look at what do these data mean. It's only about 1 out of 6 patients in the United States with high blood pressure that would actually qualify for this. So 80% of the patients that we see in the United States do not qualify for treatment that we saw in SPRINT. Also coming out at about the same time were 2 other important meta-analyses showing significant reduction in blood pressure down to around 130 with improved outcomes. These 2 trials here both show benefits for treating down toward 130, and then we have the HOPE trial, which Dr. Yusuf performed with his group, an excellent trial, which did throw a bit of a wrench into things, where they found that treatment of blood pressure was very effective with results in a low-risk group. Remember, SPRINT is high risk. If you treat low-risk groups who have blood pressure over 140, you see a significant benefit. In the middle third, no benefit, and those with lower blood pressure to start with, under 130, potential harm. And here you see the data that you see significant benefits in those that have systolics over 140, but when you begin to lower blood pressure aggressively in lower risk groups that have blood pressure that's in the 130, 120 range, it's harder to show a benefit and maybe even some harm. Another very, very important point, remember this, in the SPRINT trial, blood pressure is not measured the way you and I do it. In the SPRINT trial, the patient went into a room and sat there, doors closed, there alone, have on an automatic blood pressure cuff, and they measure the blood pressure. In our clinic, the patients frequently are running in at the last minute. The nurse puts them down, puts a cuff on. Sometimes the cuff is over their shirt, measures the blood pressure, and slips them in for us to see them. That's a different kind of blood pressure. How much different is it? Well, here are some data that show you. If you look at blood pressures automated in the office, around 132, the research quality hypertension 8 higher, and here you see even higher in routine quality practice. So the SPRINT pressures, as they are measured, are about 8 to 10 millimeters lower than what we'd be getting in office pressures. So how do we translate that to a guideline? They saw a benefit at 121. Does this mean the guideline ought to be 130 if it's going to be measured in the office? The conclusions are that there's strong evidence that lower is better than higher for treatment in selected high-risk populations. Remember that. Secondly, method is important. 6 to 8 millimeter lower using the automatic office blood pressure than the way it's done in standards. Lower risk patients actually may not benefit, and we need more data. The diabetes population was not included in SPRINT. and we saw no benefit from accord with the exception of stroke. Stroke's important. It's especially important in China. So if you live in China where you have a higher prevalence of stroke, you may want to be more aggressive in treating patients that might be targeted from stroke. And so we have this issue about stroke and diabetes, and we need more data on race and ethnicity. I want to thank you for your attention.